went to India initially as missionaries to Vellore, which is near Madras, a beautiful part of the country. And during the period that he was there, the leprosy center at Karigiri was built, where he was later director. He spent many years in India and made many seminal observations on insensitive foot. And then, after that, he came to direct the National Hansen's Disease Program here in the United States, where he was based at Carville, Louisiana, and now he is emeritus director there and also emeritus clinical professor in Seattle, where he now lives. I first met Dr. Brand in India and subsequently at Carville, and most recently in Seattle earlier this year, and it's a great honor and a privilege for me to introduce you and to welcome you here, and we all look forward very much to your presentation.
Well, thank you very much. I do appreciate this because, and I apologize for changing the title. I was told to talk about the history of the diabetic foot. But I'm 15 years retired, and I've forgotten everything that I learned. The only things I remember are some of the stories relating to my own experience. So we'll leave all the details of diabetes as a disease behind and talk simply about the neuropathic foot, because this is the basic cause of most of the destruction and ulceration breakdown. And I apologize also for not having PowerPoint. I really am not up to these things, but you'll have to forgive that. But my personal history of the diabetic foot, the first many, many years in which we were able to develop such concepts as the total contact cast and the molded insole and rigid soles for shoes and so forth, were all done not on diabetic neuropathies, but on leprosy neuropathy. And this was because when I went to India, I went to teach surgery at the Christian Medical College, and I assumed, because it was a very fine medical college, that the senior doctors there would tell me all I needed to know about tropical diseases that I hadn't studied when I was a student in England. And so, but my first shock when I began to enter the hospital, big, fine hospital, was at the gate, where I saw scores of desperately deformed patients. They weren't coming into the hospital, but they were begging from the people who left and entered through the hospital gates, and they were getting money just by pity. They were holding out clawed fingers, clawed hands. They were holding out hands that had no fingers, and they were holding out, at least they were sitting and displaying deeply ulcerated feet. And I said to an older doctor as he was going in, I said, how do we allow all these terrible wounds to stay outside the hospital? And he said, I said we should take them inside and treat them and cure some of these things. And he smiled at my ignorance. He said, oh, these are just lepers. Almost as though he was talking about some inferior race of people. And he said, if we took them into the hospital, every other patient would run away. People are so scared, they call it, the local name around there, they call it the living death, because they see that the limbs, the hands and feet, are gradually eroded away little by little, and it's not looked upon as a disease, it's looked upon as a curse. And so I tried to look impressed. He said, in any case, he said, in any case, I can see that you're looking at these clawed hands. You shouldn't be thinking about operating, because they have, all these leprosy patients have non-healing flesh. And if you make an incision for an operation, you're simply going to add another wound which won't heal. Well, this just seemed instinctively to me to be so ridiculous and such a terrible thing for a scientific person to be talking about, but nevertheless, this is what the view was, and it became, to me, a personal challenge. Somehow, I couldn't accept those words, non-healing flesh. And maybe, oh, here we are. These are the kind of course, you all recognize this. Here's a diabetic ulcer, the same as the ulcers that we see, but in fact, of course, it's a leprosy patient. And here is another leprosy patient. He happens not to have any fingers and only a stump of a thumb. And these are the kind of people who met us at the entrance of the hospital. But because we couldn't admit them, I went round to some of my old friends in England and collected some money, and we built a typical Indian village near the hospital, not too near, but and we built it of mud, just mud walls and thatched roofs. We even had a little operating room there. That wasn't a thatched roof, that was a tile roof, but in every other way, these were typical simple Indian villages. And also, because all leprosy patients that I met were beggars, I felt that they must be taught a trade that they can earn some money at when they are finally discharged. And so we built some sheds, again, mud and thatch, to teach them, and we employed some professional carpenters and plumbers and tailors and gardeners to teach these various, and also we made the one thing I think that was perhaps one of our wisest things, we admitted initially only high teenagers. I felt that these are the guys who are ready for new ideas. They were all leprosy patients, and most of them still had fairly good hands. And we admitted 25 of them, and they stayed in these little huts, and we just watched them. And I had to believe that somehow these wounds that came on the patient's hands were related to what I knew they had. They had a neuropathy. Leprosy destroys superficial nerves. And when I asked a leprosy specialist whether in fact people with leprosy wouldn't get their wounds simply because they can't feel pain, he said, well, we've thought about that, but a lot of these wounds come while the patient is still asleep. They go to bed with good hands and they wake up with wounds in their hands. It must just be the curse of the disease that's causing these things. Well, this was a real challenge, and I told these boys, these teenage, bright young boys, that they were going to be the new scientists, and they were going to discover the cause of wounds in leprosy. And it was really fun, and I could tell you scores of stories. But the thing was, every evening, at the end of the day's work, they did all kinds of work with their insensitive hands and feet. At the end of each day, we gathered all of them together, 25, and myself and the carpenter and the tailor and so forth, and we inspected every hand and every foot every evening. And it took quite a long time, but these boys knew that they were being challenged to make new discoveries. And quite frequently, at the beginning, we would find that these boys would show up with a wound that hadn't been there in the morning. And then they were put on the pillory, and we took them back, hour by hour, through that day. And we looked at all the tools that they had handled. If they were gardeners, we looked at the spades, and so on and so forth. and many of them were barefoot when they came in. They simply had little sandals. And finally, we would find, nearly always, we'd be able to find a blood stain, maybe on the handle of a spade. And we matched it with his hand, and where he had the little wound, we checked it with a blood stain on the handle, and he was teased unmercifully because these were all boys having fun. Extraordinary scientific group. But whereas in the first few weeks we had a whole lot of new wounds and a whole lot of these great discoveries, as the weeks went by, and these boys knew that they were going to be teased if they had developed a wound anywhere, hands or feet, and were being questioned about all the things they should have done, which they didn't do to protect themselves, we finally got to the point where we had very, very few wounds, and we began to feel that it would be true to say that it was simply the lack of pain, not the disease of leprosy, that allowed them to wound themselves. Until one day, a boy who had been very good and had learned to take care of himself, had learned to watch. We gave them all big handles for their chisels and tools, because we found that small chisels meant that they'd use the fingertips, and that made them very vulnerable. But here was this boy, came along in the morning to breakfast, and his hand was bleeding with a great horrible wound at the side of his index finger. And he said, all I've done is to sleep. And I remember that the other doctors had told me that leprosy destroyed fingers and hands and feet while they were sleeping. And then 2 or 3 days later, another boy came along with a wound on his foot. Again, it had happened while he was asleep, and a big piece of tissue was missing. And so we had another little plan. We divided the boys into groups, and they took it in turns to stay awake 4 hours at a time and watch the boys who were sleeping, peep through the door. And on about the third or fourth night, we had the solution. From a little hole at the base of this mud wall came a great rat. And the rat went over to the boy's exposed hand, perhaps, or foot, and nudged it and waited, and there was no response. And then pushed it harder, and there was still no response from the sleeping boy, and now he began to take a bite. And before he could go any further, the watchman at the door shouted and drove the rat away. But we had our solution. And we also were able to have an answer to the solution. I mean, a solution to the problem. We began a cat breeding colony. We had a very, very active male and a lot of willing females, and we got enough cats to give each boy. Every boy slept with a cat nestled against his neck, and then we finally got enough kittens and cats, so that from then on, for years, every patient who came into our hospital for surgery went home with a kitten to make sure that and it was in this way that we began to recognize that the significance of neuropathy, and of course it took a lot of training, but we went ahead with it, and then we began to be interested in the question of temperature. The reason was that one of my assistants, Dr. Fritchie, came to me one day when we were having a big outpatient clinic, And he said, you know, I've noticed that when a patient has only one foot insensitive, when the leprosy only affects one foot, sometimes it's quite local. He said, when they come into the outpatient clinic and I put my hands examining them, I find that the insensitive foot is hotter than the sensitive foot, sometimes much hotter. He said, I know from physiology that if you cut all the nerves to a limb, that limb becomes cooler. It may have an initial spike of temperature, but gradually a denervated limb is cooler than a normal limb. And here these, and so I said, well, let's have a study on this. And we tested all the hospital patients. But by this time we had built a leprosy hospital. This was some few years later. And in that hospital, we tested the temperature of all the patients who had only one insensitive foot and one normal foot. And sure enough, the insensitive feet were cooler than the normal foot, which is what we would have expected. Now, why were the outpatients hotter and the inpatients cooler? And we began to get very interested in temperature. And we began to study the limping of these patients on their way into the leprosy hospital was built in a kind of jungly area away from most of the roads. And most of the patients came to the hospital walking on rather rough ground. And they mostly were barefoot. And as they walked on the rough ground, we noticed that they were limping. Now, if a person has one good foot and one bad foot, which is the foot that takes most weight when they walk? Well, of course, the good foot, because you're trying to spare the bad foot. But we found that with leprosy patients with neuropathy in one foot, the pain, the foot that couldn't feel pain went smack down onto this rough road, and the good foot that could feel pain came down very gently because there were lots of sharp stones and pain-causing things on the way. And so we recognized how with a neuropathy you get a different kind of limping. You're limping to spare the good foot, not to spare the bad foot. And we found that the relationship between temperature and damage, temperature and the ultimate breakdown of a foot, was something very constant and very interesting. Now, on the way towards breakdown, you always get a phase, unless it's an obvious sharp break in a foot, but in the course of walking long distances, there comes a stage in which the foot is inflamed before it breaks down. And we began to study how pain and temperature relate to each other. And it was then that I began to study the works of Sherrington and some others. And Sherrington was, I think, perhaps one of the very first to teach us that there are two distinct types of nerve endings, both of which produce pain in every hand and foot, all over the body. And he called the first one the high threshold mechanoreceptor. Now, the nerve endings of the high threshold mechanoreceptors in all of our feet and hands only produce pain on high stress. I think if you want to bang somebody to produce pain, you need to use about 200 pounds per square inch. You can try. But Sherrington also pointed out that if a patient has already damaged the foot, and even if the foot tissues are inflamed, moving towards damage, a new set of pain nerve endings comes into effect, and they are called the polymodal nociceptors, PMNs. And they give a sensation of pain in response to a very small hit, a very small push. But the pain is very severe. And therefore, in a normal person, if you're walking in a bad shoe, or if you're walking on rough ground, or if you're walking a great distance, there's no pain to begin with, because both the mechanoreceptors and the polymodal receptors are both quiet, they're not stimulated. But even if you never stimulate the high threshold mechanoreceptors, because you're walking gently, after you've walked several miles or after you've walked on rather rough ground, you begin to get pain. But that pain is severe and is caused by much, much lower stress. Until finally, if you've been walking all day, you may be developing a blister, or you may be limping, or you may just quit. And studying these terms are difficult to explain to a patient, and yet the facts are known to any child. And therefore, I have tended to use the word tenderness. Tenderness in order to explain, because every child knows that if they are beaten with a hard beating, it hurts. But after they've been beaten several times, they become tender. And when they're tender, a much smaller blow will produce a much greater pain. And that means that no longer is it normal tissue responding only to HTMs, it is now an inflamed tissue responding to PMNs. And now people find it difficult to understand HTMs and PMNs, and therefore just use the word tender. The foot has become tenderized. And I think that it's fundamental to me that in dealing with people who have a neuropathy, you've got to work with them to help them to understand. And so we did some studies. I may not have time to go through them, but we were using, we had a volunteer. He had been an athlete, and he was a physical therapist, and he worked when I left India and came to Louisiana, to Carville, the leprosy hospital, he volunteered for these studies. And these pictures are taken with the Aga thermovision. And you can set a thermovision to measure the temperature of a limb, and you can choose a 10 degrees Celsius range of degrees that you want. And here is Harry Berkthalt, the soles of his feet, and blue is at the cold end, and it should be red at the hot end. But only part of his foot shows, because the front of his foot, the toes and the metatarsal heads, are still too cool to register. But here he is he volunteered to run 8 miles through the cement corridors of the leprosy hospital. And after running 2 miles, here is his temperature chart. And you can see that his highest temperatures is over the first metatarsal head. Now, after 2 more miles of running, you see now the first metatarsal is no hotter than it was before, but the second metatarsal, the second toe has come into view, and the metatarsal heads have become hot, much hotter over here. And now you see the second toe has become very hot. The first toe is no hotter than it was after 2 miles. And this was the hottest spot of all, here on the lateral border of the foot. Harry Bergsoldt did not know that he was limping. He had simply run 8 miles. But the foot, being sensitive to repetitive stress, the great toe had spoken to the second toe and said, look, I'm becoming inflamed. Why don't you take more of the stress? And all of us do this. Every normal individual does this. As we walk, the further we walk, the more we limp. I call it limping. It isn't an obvious limp, but we just move the foot around and adjust the way we put our weight down so as to spare the area which has already become hot, which means has already become partially inflamed, and the PNNs are active, and the mechanical stresses are not anymore in the picture. So that I like to use these down-to-earth analogies to help our leprosy patients, to understand what's going on in their insensitive feet, and what it means, because it means that the hot spot is the inflamed spot. Now, we all know, I think Hippocrates used to teach that inflammation was redness, swelling, heat, and pain. Rubor, calor, tumor, dolor. Now, the one thing these people haven't got is pain. Pain will tell you when your foot is hurting and forces you to limp. People who haven't got pain, the hot spot after 2 miles is the same spot as after 4 miles, 6 miles, 8 miles. You don't spare the hot spot. It goes on becoming more and more inflamed until it becomes an ulcer. And this has been a very helpful concept to us. And we would like to have taken biopsies of Harry Bergsoldt's feet at different levels of stress, but he didn't. There's a limit to his volunteer effort. So we went on from then with Sprague-Dawley rats. Now these rats, we did anesthetize them, but we just used the foot pads there, and here's a machine developed by our engineers which had a little piston. You put the rat's foot in position, and the little piston would keep hitting it with a chosen stress. They worked out the stress that a rat ordinarily experiences when it's running, and we made these, we put these rat foot pads there, and here is a thermograph of a rat rear end before it went into the machine, and here it is after 2 days, during which it had 10,000 repetitions of running stress. 10,000 per day for 2 days. You see how hot that right foot pad is. Now with every day we sacrificed 1 rat to get the histology of what was going on. And here you see is a normal foot pad of a rat before it has any repetitive stress. Here is after 2 days of running 10,000 paces per day. And you see that there's been some hyperplasia of the skin at the edge of where the stress, that was the area where the piston came down on the footpad. And there's hyperplasia, there are inflammatory cells around here, there's edema. We then went on for 7 days. And at the end of 7 days, you see is the footpad has ulcerated, a typical neuropathic ulcer, like a neuropathic ulcer, and you see there's a lot of destruction of tissue here. There's hyperplasia of the epithelium, and so forth. Now that was, it was 10,000 repetitions per day of X pounds per square inch. We then made a change. We gave exactly the same program to another set of rats, and this time, instead of 10,000 paces, we made it 8,000 paces. Instead of 10, 8. We didn't change the amount of force, the amount of stress, we only changed the frequency, limiting it to 8,000 paces per day, 8,000 running steps, rather than 10. And now, at 7 days, compared to that, those feet never ulcerated. They had some hypertrophy, and they had some edema. And then after 6 weeks, we just kept one of the rats going for 6 weeks. At the end of 6 weeks, with exactly the same stress, just by reducing the number of paces per day, the whole footpad became really a stronger footpad. All the edema has gone, the inflammation has settled down, and it's as good as new, or maybe better than new, because it's got a good thick thing. Now, I just want to leave these thoughts with you, because I have noticed that most podiatrists, most people who treat insensitive feet in diabetics are very concerned about the amount of stress. They use nice molded insoles, good. They use rigid shoes that don't bend but that kind of rock or roll, good. All these things are good, and they're all concerned just the amount of stress per step. But they don't tell the patient how many steps they can take per day. And we were able to prove by these footpad experiments that the number of steps per day is really more important than how much stress each one takes. And I mustn't go on with this, but let me just say there's one more thing. We had to do one more test, and that is to relate the temperature rise to the actual feeling of pain. And you can't ask a rat how much it hurts, particularly if it's anesthetized. And so we had to find a volunteer who would have his finger put into the same machine that the rats had used. And I won't tell you his name because he might get proud, but here is his thermograph before he put his finger. Now there is my hand after, oh, I'm sorry. There is my hand on the second day of being in the footpad machine and having this little piston hit my finger 10,000 times a day. But I'm afraid, I have to confess, I didn't reach 10,000. When it started, it didn't hurt at all. It wasn't a hard enough blow to stimulate my HTMs. But as the thing went on, gradually after a few hundred beats, try it yourself. Your finger begins to get a little bit red, and it begins to be a little bit painful. and then you go over 1,000 to 2,000, and now it really takes superhuman courage to stay, but you stay. And in the end, this heat in that middle finger lasts until the next day, and when you put it into the machine the next day, there is no period of no pain. It doesn't start off without pain, it starts off with pain. And before 1,000 beats have passed, an ordinary person can't take it anymore. So I just want to use this little while to emphasize the significance and the importance of temperature. Temperature is our best remaining index that a foot is about to break down. And with because I'm not in practice now, but in the days when we were doing it in Carville, every patient has a thermograph to begin with. We find the hot spot, and if he's insensitive, that will never change. The place will never change. We take its temperature with a skin thermometer, and we give him a skin thermometer to take home. It's cheaper than having an artificial limb. He takes that skin thermometer home, and he takes the temperature of his hot spot, which he's already seen where it is, and compares it to a standard cool spot, usually the side of the heel. And if the temperature differential between the hot spot and the cool spot, the standard spot, if that temperature differential persists in getting higher and higher, they are walking too many steps. It may be because they've got bad shoes and they have extra pressure, but it's a number of steps, and people don't need to count their steps. They just check at the end of each day whether their temperature differential between the hot spot and the non-hot spot has changed. And if it's increasing, then they've got to just change their lifestyle into one in which they will walk less. I'm sorry, I've gone on too long. Thank you.